Hello, and welcome to today's webinar, Tailoring Conversations and Treatment to Adolescents and Young Adults at Risk for Substance Use Disorders. I'm Tracy McPherson, and I'm going to be your webinar moderator today. If you would like to contact me about any information that you hear about today, or you want to learn more about screening and brief intervention with adolescents, you're welcome to contact me, and I provided my contact information and email here on this slide. This webinar is produced in partnership with the University of Cincinnati, NORC is the University of Chicago, the Adolescent SBIRT Initiative, the Brief Intervention Group Initiative, with support from the Conrad Hilton Foundation. I encourage you to visit our website at sbirt.webs.com to learn more about our work in adolescent screening and brief intervention, and you're welcome to contact us at the SBIRT team at norc.org if you'd like to request any information. Today's webinar is supported by the Health Resources and Services Administration, or HRSA, of the U.S. Department of Health and Human Services. This webinar is one of the webinars in our SBIRT webinar series focused on youth. We have, as you can see, a terrific webinar lined up today on opioid use. I would encourage you to visit all of the webinars in this series, including another one focused on this topic that we did just a few months ago, which is now available on demand. Today's webinar and that webinar are nice complements of one another. I would also encourage you to download the flyer and share the webinar information with your colleagues. We will have multiple broadcasts of these webinars, and then we will make them all on demand. And as you can see, you can go straight to sbirt.webs.com/webinars to get the full list. And as you can see, we also have 2 new webinars announced in the lineup that are coming up, looking at integrating STI and HIV prevention into the SBIRT model, and SBIRT and sexual and gender minority youth. The education that you're going to hear about today complements the training and educational materials that are contained in the Learner's Guide to Adolescent SBIRT curriculum. If you'd like to learn more about the training curriculum, which can be used with students, faculty, preceptors, field instructors, or practitioners in the field, I would encourage you to visit the sbirt.webs.com website. You can click on the curriculum tab, and there you can request an electronic copy of the full training guide. Access to today's materials are right at your fingertips. You can visit the sbirt.webs.com/adolescent-SUD-treatment. If you go to that page, that will be a dedicated page where we are housing all of the PowerPoint slides. Any types of materials or resources that may come up today that we would like to post after the session, they will be there as well. And this is where you're also going to find the on-demand access 24/7 after the live presentations and broadcasts. In addition to that, you will be able to request a certificate of attendance, and you will also be receiving information about how to complete a very brief evaluation survey. And I can't encourage you enough to complete this brief survey. It just takes about a minute, and we're really trying to make sure that we're learning from you about what you want and how to craft this webinar series to be able to better serve you. So we appreciate you taking that short evaluation survey. And again, we encourage you to visit the website and learn more about all of the webinars in our series. If you wish to ask questions today, you can do so by typing in the questions pane in your GoToWebinar control panel on your computer or other mobile device. Someone from our team will respond to you as soon as possible after the webinar concludes. Now it's my pleasure to introduce our webinar speaker today, Dr. Matthew Felgus. And Dr. Felgus is board certified in addiction medicine and psychiatry. He's the president of the Wisconsin Society of Addiction Medicine and a fellow of the American Society of Addiction Medicine. Dr. Felgus has a clinical faculty appointment in the psychiatry department at the University of Wisconsin School of Medicine and Public Health, and is the medical director of the Family Health La Clinica in Friendship, Wisconsin, which is a rural FQHC treating individuals with addiction to opioids and methamphetamine in an underserved area. He has been treating individuals with substance use, abuse, and dependence for over 20 years. And before he went to medical school, Dr. Felgus was a drug counselor, and he brings that perspective to treating his patients. He's lectured extensively on addiction issues to doctors and doctors in training, as well as nurses, counselors, occupational therapists, physical therapists, and as he says, whoever else will listen. He has a Bachelor in Science in Psychology from Penn State University, and he received his medical MD from Hahnemann, which is now called Drexel University in Philadelphia, where he completed a psychiatry residency at the University of Connecticut and also a research fellowship in the substance abuse at the University of Connecticut Health Center. So I am very happy to be able to welcome Dr. Felgus. And Dr. Felgus, I'm going to turn it over to you.
Thank you very much, Tracy, and I would like to welcome everyone to this webinar. Now, I don't know how many of you are having your lunches or just taking a little time out, but what I would like to do to keep everybody engaged, I want to jump right into a question, actually a poll. So I want to gauge some of these for any of you who had listened to my prior webinar. This may look a little bit familiar, but I feel like this is so important, and the content overall of this webinar will be a little different, much more focused on mental health, but I would like you all to answer this quick poll. Which are warning signs that a young person could become addicted to their opioid or benzodiazepine medication, whether it is being prescribed or not? Now, there is not just one answer, so whichever answer feels like it is correct. Like I said, there's more than one. Please go ahead and answer this, and I'll be quiet and give you a little bit of time. Okay. So actually, this is a good thing. So all of the questions, it looks like got at least 80%, and actually all of these answers are correct. Now, I'm guessing there are probably a lot of mental health counselors on this call because high current life stress is almost 100% of respondents. So good job, everybody. We are going to move on to the next question. Whoops. So, okay, looks a little bit like the first one. Same question, actually. Which are warning signs that a young person could become addicted to their opioid or benzodiazepine medication, whether prescribed or not? 4 more choices for you. Go ahead and answer which one of these. Certainly can be more than one. Feel correct for you. Okay, so it looks like this group is pretty on the ball. So now, not all of these are correct. History of past trauma, yes, very much a warning sign. Past history of other substance dependence. And that's interesting because this one got the highest response rate, 97%. But the truth is that it depends on which substance we are talking about. And I will say more about this, over the course of the webinar. But the answer to that is maybe. So if you answered yes or no, you would still get full credit for that. Ongoing prescription for the other of the two of these, yes. Cannabis use 2 to 3 times a week. This was the lowest response, still 75%. And the answer to that is needs monitoring, but cannabis use 2 to 3 times a week does not meet the criteria for a dependency, and again, certainly warrants monitoring, but not in itself a, kind of a high flag that a young person can become dependent on an opioid or a benzodiazepine. So we will and again, the purpose of those questions are just to be useful for you and also to guide me as I give this talk as far as where folks are at, and overall, you folks are a fairly educated group. So. Sorry about that. Risk factors for substance abuse, past overuse of depressants. And this is where I talked about that question that it depends on, what substance somebody has had a past dependency to, whether or not they're going to be more vulnerable to central nervous system depressants like opioids, benzodiazepines, as well as alcohol. So past overuse of those central nervous system depressants certainly increase the risk of overuse of one of the others. So the reality is if somebody's had an alcohol dependence, they are much higher risk of becoming dependent on a prescribed or unprescribed opioid or benzodiazepine. This is likely a greater risk than somebody with past overuse of other substances, stimulants such as cocaine or cannabis. However, both the MD and the patient have to maintain awareness, and it doesn't say this on the slide, but just in my clinical experience, I would say that we need to talk to the patients and clients. We all know folks who will just overuse anything that they can get their hands on. Those folks are at high risk for any substance that they start using. There are other folks that really do tend to prefer. There are people who just abuse all different types of speed, and they get an opioid and they don't like opioids and they do not abuse it, or they say, I've never been a drinker, I just like speed. So the answer is we just really need to do good screening on everyone that we see, because in many cases the answer is it depends. Now, this webinar is not going to just be limited to opioids. The first webinar I did, we just talked about opioids. This webinar is going to get a little more global into there's more than just opioids as far as substances of abuse. And obviously opioids are very important, causing a lot of deaths right now, but we can't lose sight of, all the other substances, both prescribed and street, that folks out there are using. Risk factors for abuse of opioids, and I spoke more about this in the first webinar. If somebody takes an opioid for the first time and gets energized from it. Now, most people do not get energized from opioids. They get clouded, they get tired, it just takes away pain. There are a subset of people for whom opioids actually cause them to become energized and euphoric. These folks, this may be their first experience. They are certainly not dependent on opioids yet, but this is the very high risk group. And even if even if the individual hasn't tried it yet, if they have family members who have become energized on opioids, they are at high risk. And this is a factor that a lot of people are not talking about. They should be. When I give this talk to surgeons, they all, you see the light bulbs go off because they're all saying, oh my God, yes, this makes perfect sense. I've had people like this in my practice, and pretty much people say this across the board. So risk factors, that energy, the euphoria, numbing of emotional pain, and it sounds like just about everybody on this call recognized past trauma, past mental health issues, going through a lot of stressors in life. Absolutely. Opioids numb out pain and they numb out emotions as well. So high risk factor. As I mentioned, current high life stressor, past trauma, genetics, other people who have been abusing or dependent on opioids in somebody's genetic line, and greater than 7 standard drinks. Standard drink being defined 12 ounces of beer, 5 ounces of wine, 1.5 ounces of liquor. 7 standard drinks. If somebody is consuming more of that, that's a fellow central nervous system depressant, and they are at higher risk of abusing an opioid. So again, this is primarily about education, and we talk about education, not punishment, and I think those are just important ideas to keep in mind. Higher risk factors does not mean that somebody is intending. The majority of the people that I have come across, that I've treated, that I've met, that have become dependent on a substance will say, I never thought that this could happen to me. They certainly were not planning to abuse the prescription medication that they received for the most part. And it just happens. There's just that biochemical reaction. Sometimes it is necessary. My folks that are on medication-assisted treatment, the ones that are very, doing well in their recovery, one of their greatest fears is, oh my God, what happens if I ever need surgery and I'm going to need pain medication? Sometimes it is necessary to utilize this type of medication in somebody who is high risk if they are having surgery or they are in a serious accident. And there are ways to do this as safely as possible, and people really need to stay aware. That includes the prescribers, the counselors, family members and friends, and the individual themselves. It can be done safely if everybody is on board and there's a good plan. Educating that someone is at high risk in a non-judgmental way can make a major difference. And I'm going to show you a slide next on the, just a brief conversation to have with people. The other thing to keep in mind is with a younger population, this is a population, they tend to feel invincible. They know more than the folks older than them. They do not like being told what to do, and they need to experience things on their own. Not only are their brains not fully developed until about, their frontal cortexes until about 25, but they're not very good listeners because they know it. And we do have to factor that in when working with this, with a younger population. Now, this is, I talk to other medical people a lot, and one of the responses that I hear is, I don't have time to do screening and to educate my patients, especially if they're surgeons, on risk factors, before I prescribe them pain medication after their surgery. Well, here is, and I should probably say this probably takes about 1 minute, but a less than 3-minute conversation for all patients prior to an opioid prescription, whether they're at high risk or not. If you feel energized after taking this medication, you need to call the office and let us know. This shows you may have the brain wiring to develop an addiction to this type of pain medication. It is based on genetics and isn't anything you are doing wrong. It is not about willpower or good character. It can happen to anybody with this type of brain wiring, and most people don't know they have it until they take this kind of prescription. However, this means you need to be very cautious with any opioids. Never take extra, and if you can, have somebody else hold it for you. And again, taking a look at this, we are not accusing anybody of anything. We are not telling people that there's something wrong with them. We are just stating the facts. You don't know if you have the brain wiring until you try it, and unfortunately, once you try it and start feeling a little too good, if you do not realize what's going on, what are people going to do? They're going to keep doing something that feels good. So run this through your own filter. This is what I tell everyone whenever I give a talk. Everything I say needs to make intuitive, clinical sense to you, whether research backs it up or not, quite honestly. We all have our own filters. We all know what makes sense. So this needs to make sense. If it doesn't make sense, honestly, I absolutely want you to please ask questions, submit questions, and we do answer them. So medication-assisted treatment. Now, this is not going to be the focus of this talk, but it obviously is important to say a few things about it. And I'm going to speak in more global terms with medication-assisted treatment, because what I'm doing, I want you to have things to think about more than a, how-to stepwise manual on how to do it. How we offer medication assistance does matter. One way to do it is medication is one tool, in treatment, recovery meetings, all of, healthier eating, exercise. Medication is one tool versus medication is the tool. And I think intuitively, most people would say, well, of course, medication is only one tool, but it does not surprise me. It's very easy to fall into the trap of just giving people medication because it's quicker, it's easier, it's less of a use of resources. And wherever you are, whatever your programs are, please stay aware of that as professionals, not to fall into that trap, because it is easier than all of the, other things. And it's easier for patients too. How many patients come in, doc, just give me a pill, any pill, I want something to fix this. We need to deal with the underlying issues for effective treatment. And again, I don't think anybody would argue that, but it is easy. Doctors, we're compassionate, and what do we know? We know medication. So it is real easy to fall into what we know and not pay as much attention as we should. This is an actual quote from a young patient of mine, came in just for his monthly appointment. I'm feeling more stressed. This past month, I almost got fired from my job, and my girlfriend is saying she doesn't know if we should be together. I'm having more cravings. Can I get an increase so I can feel more comfortable? He said this in all honesty. This was a teachable moment. He was on buprenorphine. I did not increase him. He was probably a little disappointed, but what I did was engage in a conversation. Now, there are other facilities, and I know several of them, that just would have increased this young man. Oh my God, you're having a craving. We don't want you to use. Okay, we're gonna bump up your opiate replacement. And this is, I guess what I'm appealing is to say that there is another way. Medication-assisted treatment, it is not a wonder pill, film, or shot. How we give medication can be more important than what we give. We know this. Research backs it up. The medication plus guided healing, and I'll talk more about healing, but that just means good treatment. It's mental health treatment. It's drug counseling. It's, nutrition. It's exercise. It's healthier living. It's teaching people meditation. All of this stuff actually works well. Telling clients, so setting the expectation, and I do this all the time, medication is just one piece of the puzzle. I think it is so important to set that expectation with your clients. And the other thing to keep in mind, we talk about, I talk about guided healing. I talk about healing a lot. MDs are not trained in healing. We're trained in how to provide medications. So it's wonderful, and we all know MDs who are about much more than just handing out medication. But sometimes I think, and I'm an old drug counselor, but sometimes we as the counselors and the therapists actually have to guide that discussion. It's real. Sometimes it gets easy to let the doctor, kind of carry the treatment. But the reality is the role of the counselors, the therapists, the ancillary, even the physical therapists and the OTs, quite honestly, is equally important to the role of the MD. So movement in medicine, medication, all capitals, assisted treatment. Movement in wellness, and we are talking a lot more about wellness. Medication, assisted, emphasis on the treatment. We could still be doing the same thing, but we could be focusing very differently. So one area, and I want to say a little bit about this, I'm going to move more into talking about the mental health. We hear a lot about, there are all kinds of pharmaceutical companies and researchers that are trying to find medications to address cravings for opioids, for methamphetamine, for alcohol. So medication for craving, yes, it can be helpful. However, and again, just giving you folks something to think about, any craving medications are only going to work to a point because they are not going to address the underlying mental health driver. Can we give somebody medication for cravings if the craving in the recovery community, we talk about people, places, and things? Well, if you go by that street corner, or if that family member or your dealer comes by, or you run into somebody you used with in the gas station, how far is your anti-craving medication going to go? So I am not against anti-craving medication, but we cannot over-rely on it. We need to be doing more for our folks. So yes, there is a biochemical change in the brain that may be eased for some people with medication, but we can't just sit on our laurels with that. And this is what I spoke to. What exactly is driving a craving? Is it just neurotransmitters or more? And if it is just more, this is where we all have to be realistic about what medication is going to do. Can it help? Yes. Is it going to be the be-all and end-all? Absolutely not. But I've seen too many patients that really are pinning all their hopes on this medication that they're going to take is going to eliminate all their cravings, and they're very disappointed or upset, or they don't know how to cope when their cravings break through the medication. Will we ever create a medication that can eliminate cravings solely by impacting our neurotransmitters? I'm going to go out on a limb and say we are not. There is a lot of money being poured into that right now, just with the challenges that we have in treating substance use disorders. But are we going to eliminate, just with a medication? I would say not. But the question, to treat or not to treat, we need to treat. So hopefully it doesn't sound like I'm talking out of both sides of my mouth, but medication is important. It does lower morbidity, and most non-addictive medication is not harmful, even with substance use. So we do have to be careful. I've had folks with alcohol dependence who are on an antidepressant. They relapsed on alcohol, and they're trying to be responsible, and it may even say on the label of their antidepressant, do not take with alcohol. So they're trying to be responsible, so they go off of their antidepressant because they've relapsed on alcohol, and that actually makes a bad situation worse because now they're consuming a depressant and they just stopped their antidepressant. So reality is most non-controlled substances, you can take those, even if somebody is using substances. So the idea of treatment, and again, I'm talking about wellness again, but helping people to heal what's inside them or to help them numb out. And we are living in a quick fix, easy out culture. Our media is reinforcing this. And I'm going to talk a little more about cannabis. Now, I am not taking a position on whether or not cannabis should be legalized. The reality is, I think it's going to happen in our lifetime. When you look at the millennial generation, over 70% of them are. It does not matter what end of the political spectrum they're on. Over 70% of them are in favor and see no reason why cannabis should not be legalized. And those folks are going to be running the country not too long, not too far away. So the idea, different question from legalization, this whole idea of marijuana as medicine. The answer is that depends. More research is needed on things such as pain and certain types of neurological conditions, but the idea of using cannabis to treat anxiety or to treat depression, again, I would ask you about the first bullet point. Are we helping people to heal what's inside them or helping them numb out? So when I'm doing a dual diagnosis evaluation, so looking at somebody, which is honestly somebody that has a substance use disorder, the likelihood of them not having a concurrent mental health condition is very, very low, and I'll speak more to that a little bit. But I think it is important, and obviously we don't have time for me to go through a whole dual diagnosis evaluation, but there's some things that I think are important to keep in mind. The relation of symptoms to substance use. So when we do substance use, in most of the clinics I'm familiar with, we're going to find out, okay, what drug are you using? What's the frequency? How much are you using? And when was the first time you use? And we just go down the list, and there's some very nice screens to do that. What we don't pay enough attention to, and I would say I think we should all be asking, is what is the relation of one's symptoms to substance use? So it's not just enough to know that somebody is using, methamphetamine 3 times a week, or, they're using heroin every day. I am always going to ask why. What is it, what's it doing for you? So if somebody, if the result of use, somebody can be, trying to escape or numb out. They may be trying to make their mood go up or down. If somebody's too hyper, they're trying to chill out. If they're depressed, they're trying to, kind of pick themselves up. I've also seen people that are using stimulants that are not their own, not because it gets them high, but because it's actually helping them focus, be more productive, keep their job. So it really is important to ask. And we don't tend to do that enough. We just focus on the numbers and the frequency and things like that. So this is a piece that's important that's being missed. The other thing that I've seen clinicians do is focus a little more on, oh my God, is this a substance-induced anxiety disorder, or is this a freestanding anxiety disorder? And the reality is, if somebody is sitting in your office, they are abusing whatever substance it is that they're abusing, and they are also experiencing high anxiety or major depression, it doesn't matter as much as you think which came first, because the reality is a substance-induced depression versus a major depression, you still need to treat it with antidepressants. It's just going to have a different trajectory. And the other thing, and this is just one of those, things that a lot of people don't think about, I would say over 50% of the time, which came first, if it really does feel important to find out, asking the patient. Now, some patients will say, well, I've been using since I was 9 years old. I have no idea what I feel like when I'm not using. But in my experience, my clinical experience, I would say over 50% of patients will be able to tell you which, whether the mental health, whether their depression or anxiety came first or their substance use came first. So just try it out. Now, the mental health, I talked about this at the first webinar that I did. I have been in the field, if I count my drug counselor days, I've actually been in the field coming up on 30 years now, and I have not evaluated one individual, even as a drug counselor or as an addiction psychiatrist, that does not have one of these, I call them the mental health big four, for driving addiction: depression, anxiety, trauma, or insomnia. Now, I have people that will come in and say, nope, I don't have any of those. I'm just an alcoholic, or I'm just, I've just got an opiate addiction. The reality is when you dig a little deeper, it's there. It's just hard because some people, when somebody's been numbed out for all of their adult life, it's sometimes hard to tease it out. But even if they're not acknowledging it in the beginning, keep an eye on it. So I'm going to say some things about different dual diagnosis. Depression is frequently overlooked in teenagers. There's a lot of reasons for that. They're out of touch. They're not very good historians. They're often out of touch with their feelings. They may be in treatment under duress, so they're not going to be as open as they could be. And with younger adults, you see this in kids all the time, just about. In adolescents, it's a mixed bag, but behavioral problems may be the main manifestation of depression rather than what, the typical melancholy that we think of. Depression plus alcohol use equals extremely common presentation in the mental health setting. It is very easy not to ask, and it does not take a whole lot of weekly alcohol to affect mood, and this is actually below the quantity where we would start diagnosing an alcohol use disorder. For males, you need over 14 drinks, so 2 drinks a day, over 14 drinks a week to diagnose an alcohol use disorder, but it's really only half of that can affect mood. Again, keeping in mind alcohol is a depressant, so somebody may not be meeting the criteria for an alcohol use disorder, but they still may be drinking in a way that is lowering their mood. And if you don't ask, this could fly under the radar. Both alcohol, opioids, and benzodiazepines, I would include that on this slide, are central nervous system depressants that cause and worsen depression. However, from the patient or client's perspective, it feels like it's self-medicating. Number one, because it numbs them out. Number two, because with just about all of these central nervous system depressants, there's a little bit of a bump up in norepinephrine. So I guess you can make the argument that something like alcohol or opioids, is this a little bit of an antidepressant if it's bumping up norepinephrine? I could think of much better medications than alcohol or opioids to increase norepinephrine. But there's a little bit of a bump, nowhere near as much as, if they were taking a medication that actually worked on norepinephrine. So depressed drinkers often cannot maintain sobriety if the depression is not treated. However, alcohol may neutralize medications for depression. And again, it's not dangerous, but as I tell my patients, what do you think happens if you take an antidepressant plus a depressant? It's going to make the antidepressant have to work much harder, but again, it is still worth treating. So we're going to move on. I'm going to say a few things about cannabis. Now, the cannabinoid receptor, it does seem to have some effect on pain control. And again, more research is needed. There's a whole lot in the pro-cannabis legalization literature around pain control, and people are making the argument, well, since, you're not going to die from cannabis, shouldn't people be using cannabis for pain control rather than opioids, which are more dangerous? And more research is needed. Now, the other thing that's important about the cannabinoid receptor that I think people are not paying as much attention to in this day and age is that because there really is a receptor, having a receptor in our brain does lend itself to both physical and psychological dependency. Now, we have known since the late 80s that there is a cannabinoid receptor. You can develop a physical dependence. I have had this debate with more otherwise very well-educated people, including therapists, that will argue that there is not a physical dependency with cannabis. The answer is that there is a physical dependency with cannabis. If it is going to be, if it does wind up being legalized one day, which I do think it will, regardless of my position on it, we need to be educated. And this idea that cannabis does not have a physical dependency, I think we're doing a lot of harm to our young people, because I think if you took a poll, I think the average individual under 30 would say that no, cannabis, there is no physical dependence. Again, I just mentioned it binds to the mu receptor, which is the opioid receptor. So we really do need to do research on pain control with cannabis. Now, cannabis mimics, it is not a direct depressant like the central nervous system depressants I was mentioning before, but it does mimic some symptoms of depression. The amotivational syndrome, I'm sure most of you are familiar with. People just don't seem like they want to get off of the couch. It does impair ability to learn, and it does diminish concentration. Now, these aren't debatable issues, regardless of, what somebody feels about, their support of cannabis. This is what it does, and we do need to be screening for this, because this is, for somebody that's using cannabis regularly, this is the presentation. It is very common to medicate anxiety and depression with cannabis. Again, it numbs people out. Now, most people, I certainly did when I was younger, knew people who said that they get paranoid when they smoke. If you know nothing else about somebody that says pot makes me paranoid, you can diagnose an anxiety disorder. The only people that get paranoid when they smoke are people with anxiety disorders. People who have true paranoia, under the rubric of psychotic conditions, their paranoia and their psychotic symptoms actually seem to improve although it worsens the outcome. So somebody who is developing schizophrenia, it is actually a very common presentation among teenagers who are prodromal for schizophrenia to discover that marijuana actually seems to control their symptoms. That's their perception of it. It does worsen the outcomes. There's good research. Regular cannabis use in individuals with psychotic conditions, it is actually harder to treat the psychotic condition if they're using cannabis regularly, but it actually makes a whole lot of sense for these teenagers who are prodromal for schizophrenia to get, to really discover that in the beginning, cannabis feels helpful. So there, obviously, I've talked about this. There is certainly a decreasing perception of harm with cannabis, increasing belief it should be legalized among the U.S. population, and this whole idea of medical marijuana. Again, there's no research to really back up the idea of medical marijuana, but any time it's being used primarily, and I'm not a pain specialist, I cannot speak to pain or certain other conditions, but when it's used for mental health conditions, anxiety or sleep, it's really, you're really looking at, and I challenge my patients on this, are we numbing out more than we're treating? There's no evidence to back up these claims, and there is a potential for dependency when somebody's using it to control anxiety, or that, they say that's the only thing that helps them sleep. Now, CBD oil, so the less psychoactive cannabidiol, it does show potential for treating pain, seizures, neurological conditions. More research is needed. It can be made from cannabis or hemp. It is not highly psychoactive. However, it varies from state to state. A small quantity of THC is allowed. I'm not familiar with all states. Where I live in Wisconsin, the CBD oil is allowed to have up to 0.3% THC content. Now, I liken that to non-alcohol NA beer, non-alcoholic beer. We usually discourage alcohol-dependent folks from consuming non-alcoholic, the NA beer. If somebody drinks about 50 of them, they can probably catch a buzz. If somebody uses a whole bottle of CBD oil, you can probably get a buzz. That's going to be phenomenally expensive, however. But again, I just think more research is needed. I think it is a very fascinating chemical. As far as stimulants, most of this we know. I mean, cocaine, meth, prescription stimulants, Adderall and Ritalin, they can cause anxiety, depression, psychosis. The difference with stimulants, the hallucinations. So how do you know if somebody's got a schizophrenia type psychosis versus if this is just a drug-induced psychosis? With the hallucinations, if this is just from the stimulant, they tend to be more touch. They'll feel either bugs crawling on them or somebody touching them. With the more psychotic disorder hallucinations, those tend to be more auditory or visual. So type of, it's not just enough to know somebody has hallucinations. Type of hallucinations do matter. I have seen many people get misdiagnosed as bipolar when they were abusing a stimulant. It is interesting how many times, even in hospitals, people aren't asked what they were using when they came in. Now, what's interesting, stimulants will have a paradoxical effect on true ADHD. Now, the sad reality is that the majority of people who are prescribed a stimulant for ADHD, in all likelihood, do not have ADHD. People who truly have ADHD, this is a real condition, it is a brain wiring. Folks that have true ADHD, stimulants do not get them high. And that is something actually very unique to the population that has true ADHD. So stimulants tend not to be a drug of choice for this population. So if somebody does have a history of abusing coke or meth or Adderall or Ritalin, I would say there's not a 0% chance that they have ADHD, but it's not very high, but people need to be very careful, and I would avoid stimulants. Now, I wanted to provide you with my differential diagnosis because poor concentration is such a common symptom that people come in with, and patients just want to jump to the conclusion, well, I can't concentrate, I must have ADHD, so you need to treat me with a stimulant. Well, I just ran through off the top of my head just differential diagnosis for poor concentration, and this is something I think that can be helpful running through this with clients. Not enough sleep, trying to do too much at once, distraction of social media, anxiety, depression. Those mental health conditions do cause poor concentration, and I'm not done yet. Not interested in the subject or task, stress, past trauma, alcohol or other drug use, other learning disorders that are not ADHD, and then finally actually having ADHD inattentive type. So all poor concentration is not ADHD, and I think it is really important to educate people about that. Checklists are limited. I encourage people to take a good history, include family, teachers if possible, assess for prior abuse of stimulants. Comprehensive psychological testing really is the gold standard. Not everybody has access to that. We do the best we can, but whenever that is available, I will always send my patients for that. And in past abuse of stimulants, you really need to beware of prescribing them. So as far as moving on, so talking about hallucinogens now, LSD, DMT, other hallucinogens, psilocybin, mushrooms, they can precipitate psychosis in those predisposed, likely genetically vulnerable. However, research is being conducted to treat PTSD, anxiety, depression, end-of-life angst with hallucinogens, and the early research actually looks promising. So this is an interesting area. So things can change. Substance abuse that is advancing may cause, a bunch of things, an increase in mental health symptoms, separate from the drivers, the underlying drivers, the inability to perform usual activities, loss of social support, and then relying on the drug for coping with any of the above. So again, it's just staying on top of what's going on. So warning signs. Trying to cut down on my use, but I'm going into withdrawal. Now, is it always withdrawal? This is a segue into anxiety. Anxiety can present as all kinds of things: general unease, panic attacks, social withdrawals, phobias, obsessions, compulsions, and it is very common for both teens and adults to treat anxiety with any substance. So we do have to be aware of anxiety. Opioids and anxiety, extremely common presentation. There is a high degree of overlap between withdrawal and anxiety symptoms, and anxiety is a major barrier for individuals to stop using. Opioids, as I mentioned, they're wonderful numbing agents, and people with anxiety as well as PTSD absolutely want to be numbed. And we do need to be mindful about our messages. It is very common so what I have here, I have a graphic, and this is also in my first webinar. These are just the symptoms of anxiety, put in a little circle, and these, I don't think anybody would question that these are anxiety symptoms. Now I'm going to show you the next slide. These are actually symptoms of opioid withdrawal. Now, I'm not going to toggle back too much. You guys can do that when you have access to the slide set, but you probably notice that these are almost the same symptoms. Other than goose flesh, runny nose, watery eyes, pretty much anything on this list can belong to either condition. So it is very common for individuals who are in opioid withdrawal, but they're also having anxiety. They just attribute it all to opioid withdrawal. And these folks can often wind up on more medication than they need. So somebody who does, who's addicted to their prescribed medication, now what? Encourage honest, open dialogue. How much they are taking, they could be taking more than what they're getting in a prescription. Do not, because most physicians are not educated or trained in addiction. We do not get that training in med school. So the response of many physicians to finding out that their patient has a dependence on the medication that they're prescribing is to just cut them off. So again, as the counselor, as the therapist, you do have a potentially important role. Do not encourage a physician to cut off your client's prescription at the first sign of a problem, your client will often turn to the street for more pills or heroin. However, there does need to be a contract, no early refills, slowly lowering the dose. You want to try to get them in treatment. So there is a path, but just that knee jerk, that's it, you're totally cut off, that's not helpful. Screen for the big health mental four, or excuse me, the mental health big four. And then there are the available screens, the PHQ, the GAD, the HAM. These are all excellent screens to screen for these conditions. And you do need to do that. It is important. Opioid abusing depressed individuals will usually have their use brought to attention before their depression. So again, we need to screen. We can't ignore that. And the greatest risk is of respiratory depression. That's, high risk for the individual to stop breathing in their sleep. And opioid plus benzodiazepine is a recipe for an overdose. Both of these medications, or both of these, this class of substances will actually slow down respirations, and combining them, I see no reason for any doctor to ever do that, but it is unfortunately still too commonly happening. Now, the connection between, and not everybody uses that AODA diagnosis, so that's alcohol and other drug abuse. That's actually, I think, an acronym unique to Wisconsin, so I apologize for that, for anybody that's not familiar with that. But the connection between substance use disorders and trauma. Folks that have had a lot of trauma, especially childhood trauma, never learned to manage feelings in a healthy way. Oftentimes they'd had bad modeling from family members who, also have had trauma in all likelihood. And drugs feel like the perfect solution to getting rid of memories and unpleasant feelings. So how to help? Again, help your clients notice the connections between use and what they're feeling. First question I always ask when somebody informs me that they've had a relapse, I want to know two things. Number one, I want to know what was going on at the time. How did the relapse happen? Second question I'll ask, not in a judgmental way, but what did they learn from it? And sometimes I can just tell that by talking, but I will sometimes ask that directly. So notice the connection, whether they've had trauma or not, between use and feelings, and recognize, especially with individuals with PTSD, recognize that as use lowers, uncomfortable feelings are going to increase. However, as coping increases, the feelings are going to become more manageable. So that's kind of the hang in there. And I think it is important to educate individuals with PTSD who are using substances. Decrease use if unable to fully stop. And again, this usually does work with folks that have PTSD. You want to work on harm reduction, getting the use down. The goal is to stop, but you kind of want to move them in that direction. Work on both trauma and use together, and refer to trauma treatment. And I just listed some. There are many, and it's increasing and improving the types of trauma treatment out there. And that would probably be another 1-hour webinar. Insomnia. It is important to assess the type of sleep problem. So somebody comes in, I can't sleep. That's not enough information. There's a bunch of different ways to have insomnia, and these are, it's important because you can get a lot of mental health information on how somebody can't sleep, not just that they can't sleep. So can't fall asleep. So that's, the first type of insomnia. I can't fall asleep. Mind racing or worrying, feeling too awake, afraid that something bad's going to happen, fighting, sleep or multitasking or being online or, all those other things that people are just staying up too late. So again, tease this out, because you're going to come across a lot of mental health conditions. Mind racing or worrying, that's an anxiety disorder. Insomnia is the symptom, but the anxiety disorder is the driver. Waking up in the middle of the night, that's another type of insomnia. I can fall asleep okay, but I can't stay asleep. So again, how many times? How long are you staying awake? Or is it that you're sensitive to noise? Are you having nightmares? Again, that might be PTSD. Are you having anxiety or panic feeling? Are you waking up because you're snoring? Possible sign of sleep apnea. That's a different kind of evaluation. Waking up earlier than needed and unable to get back to sleep. How much earlier? How much sleep are you getting for the night? I had somebody that was complaining that they were getting up every day at 5 o'clock and they didn't need to, but they were falling asleep by 9. Their body was getting enough sleep. That's not insomnia. Are they feeling rested? Are they waking up feeling panicked or worrying? Again, this is all things that we don't tend to tease out with insomnia. Can be caused by any of the mental health big four or a medical issue. And individuals, I bring this up and it's important because individuals may feel the urge to knock themselves out with substances, including alcohol. Short term, this seems to help, but over time, this is going to worsen sleep problems. Non-medication ways of helping with sleep are very important. Mindfulness, avoiding blue light, so trying to get people offline an hour before bed, avoiding caffeine 6 to 8 hours, avoiding naps, and recognizing and guiding them. Sleep and early recovery is often challenging and usually will improve, and we can treat it if it doesn't. As far as medication treatment, avoiding the addictive sleep aids, extremely important. Melatonin can be helpful. Now, some people don't take enough melatonin. You need to take 9 to 10 milligrams for an effective dose. And other non-addictive sleep medications can be considered by prescriber recommendations. So there are definitely other medications, things like trazodone. There's a bunch of them. So implementation of medication, I wanted to say this just as a shout out to, the FQHCs. Medication for opioid use disorder in adolescents and adults is more effective than behavioral treatment alone. And we've got choices. Are we, going to prescribe buprenorphine? Are we going to prescribe naltrexone, Vivitrol, or the pills? Are we going to prescribe methadone? Take a good history. Know your mental health drivers. The question, my opinion, there should be a requirement for counseling, but these are all questions. Folks who are setting up these kind of programs, you do have to figure this out. What is your policy? And I don't have the answers. There's more than one way to do it. Policy on other drugs in the system, you got to get clear about that. Is buprenorphine going to be allowed to be started if the individual is using methamphetamine? What about cannabis? These are all, you've got to have your policies straight. As far as buprenorphine, there's different ways to do buprenorphine. Do you slowly taper it, or is it long-term maintenance? A carrot to keep people in treatment. Do you not get a prescription if you miss an appointment? You have to, as any type of program, whether FQHC or not, maintain awareness of the risk of diversion and abuse, even of buprenorphine. What is the policy on benzodiazepines, which I'd mentioned, recipe for an overdose. Talked about over-reliance on medication versus recovery tools, and then higher level of care. If this is not effective, what do we do? So these are all important. Injectable Vivitrol, treatment requirement. I'm going to allow everybody, hopefully everybody can see this. We don't want this given under duress. Injection as leaving incarceration or rehab does help. It's not an opioid and does not numb, so people can still have cravings. And just keeping in mind the pain medication is not going to be as effective. So final thoughts. It is very important to get treatment for mental health as well as substance abuse in a dual diagnosis population. We offer our best advice and expertise. We cannot make anybody ready for treatment, but we can offer compassion along with good boundaries. So thank you very much, everybody. And please, any questions, please send them along.
Well, thank
you,
Dr.
I will turn this over to Tracy.
Yeah, thank you so much. Well, a terrific material today that you've covered, so much to learn, and I think we can go through your presentation several times and just keep learning and learning. So thank you very much for sharing your expertise with us. And as Dr. Felgus mentioned, if you want to submit a question, go right ahead. We will try to get back and answer those questions as soon as we possibly can, and they will be available up on the website. You also find the PowerPoint slides, and this is where you will also be able to request certificate of attendance. You'll access the session today 24/7. And as a reminder, we will asking you to complete a very brief evaluation survey. As I mentioned, it's really important to us. And look for that follow-up email that will give you information that you need to be able to access all of those things. So I also just want to thank everybody for joining us today, and to remind you of some of the SBIRT technical assistance specifically around adolescents, that we're glad for you to contact us, and you have some questions about materials. Could be about this webinar, it could be about the website, or just materials in general, and you want a little telephonic technical assistance to get you pointed in a certain direction, or questions about implementation of education, training, evaluation of that, I encourage you to reach out to the SBIRT team at norc.org, or to me directly at mcpherson-tracy@norc.org. And last but not least, I just want to thank all of you, Dr. Felgus, and all of our participants today who are attending with us, and for all of our partners who make the terrific webinar available. And I would encourage folks to visit these organizations' websites, learn more about them, and also learn more about the adolescent SBIRT education and training materials at sbirt.webs.com. So with that, I'm going to wish everyone a great rest of the day, and thank you so much for being with us.